Okay, good morning, everyone. Thanks for joining us for this second series in innovations in diabetes and cardiovascular health. I'm Goutham Rao. I'm the director of the ECHO program within Cardio. So as we go through this series, I just want to remind folks, and we've actually been pretty good about this over the last 4 years or so, to avoid using any private health information in your case discussions. Of course, names, locations, primary care physicians, etc. So basic common sense. You can use initials. You can use just a letter designation for a name as you go through it. So if you have any assistance needed or concerns about technical issues, Rick is always available, and his email and phone number are listed there. If you have any general comments, questions, feedback, please contact either Claire, who's our coordinator, or me directly. Please take advantage of that. ECHO is a community of learners. Even though you're enrolled in this one series, it doesn't mean that your participation is over. You're welcome to return. We have many return participants in series after series. Plus, you're always welcome to ask questions of our experts or our team in general. So this is a brief slide about cardio. It's hard to believe this is our 6th year that we've been around. So the mission of Cardio is to improve cardiovascular and diabetes health outcomes and eliminate disparities in Ohio's Medicaid population. It's quite progressive when you think about most states don't have something of this sort. It's actually an initiative of healthcare professionals who are connected with Ohio's 7 medical schools. And we identify, produce, and disseminate evidence-based cardiovascular and diabetes best practices to primary care teams. And so ECHO is one mechanism that is, of course, popular all over the world now. I think a couple of billion patients have been affected by ECHO, which started in New Mexico about 20 years ago, is one way to actually disseminate evidence-based information. But I think that just giving out information doesn't do a whole lot. There has to be an interactive discussion, of course, and some thought that goes into it. So most of our participants are highly motivated to improve cardiovascular health, and they do get a great deal out of it. We also have monthly newsletters and online repository of resources at cardio.org, podcasts available, and of course, Cardio Radio and the ECHO model. So I head up just the ECHO program within it. We have a number of content experts. I'm not going to read through all of these names. And, they all have different perspectives on things, and they'll comment on different aspects of things. And it's important to keep in mind that even if we ask someone who's not a clinician to comment about how they might improve blood pressure control in the patient, it's because we're interested in their perspective. You don't have to be a blood pressure expert. You don't have to be a disparities expert, but everybody has experience that they can contribute. And that goes for not just for our experts, but for our participants as well. So every series, I have learned something about how to improve cardiovascular health in my patients. And probably in every single session, there's something to be learned as well. Next slide. And as you can see, we have a very robust regional representation from across Ohio. This is deliberate, so we try to recruit people who are connected with the 7 medical schools from all specific regions of Ohio, Southeast, Southwest, not just the big centers, Ohio State and Case Western, but the other schools as well. These are our disclosure statements, and these will appear in advance of any presentation that you see. If you have any questions about these disclosures, please do contact me directly, and I will contact the speakers and let them know that more information is requested. Okay, I'm going to turn things over to Dr. Liz Beverly for a couple of minutes to talk about patient-centered language that we'd like to use throughout this series. Liz?
Thank you, Dr. Rao. I'm going to take a few minutes to talk about language. So just a little context into why we're talking about patient-centered language. So at Cardio, we're going to be talking about cardiovascular disease, type 2 diabetes, and other comorbid conditions. We know that these conditions come with a social stigma. And with this social stigma, research has shown that stigma can have a negative effect on someone's physical health as well as their psychological health, and it can also lead to less access to care and receiving adequate care. One of the things that we can do as a community is we can work on destigmatizing these conditions, and one of the ways to do that is with the language that we use. So I'm going to present some of the language here This is from the American Psychological Association. So in talking about this, if we're going to talk about gender, remember gender is a social construct and it's a social identity. So let's use the term gender when we're referring to people as a social group. If we're going to talk about sex, let's refer to it as assigned sex at birth, and refer to it as a biological distinction. Race is also a social construct. It can be used very broadly to categorize people based on physical characteristics, behaviors, and geographic location. It's not a proxy for biology or genetics, but that doesn't mean that race is not important. It's important, especially if we want to look at access to care, quality, and outcome data so that we can help identify disparities within the healthcare system. Sexual orientation. We want to use sexual orientation rather than sexual preference or sexual identity. Remember that people choose partners regardless of sexual orientation, but sexual orientation is not a choice. In talking about disability in the disability community, it should be indicated only when it's relevant. And disability language should be to maintain integrity of an individual, and it should be used to convey what the preference is. If you know that preference of an individual, if you do not know the preference, it should always be patient-centered by saying something, the person with a specific disability. When talking about socioeconomic status, providing very detailed information by stating an income or education or their specific employment, but we want to avoid pejorative terms by saying someone's homeless or just saying that they're poor. And then a newer one is avoiding some violent language. And this is something that I personally am working on. There are a lot of sayings that we have in American colloquialism where things like, oh, I'm killing it, or let me pull the trigger on this. Let me take a stab at it, or someone went off the reservation. And these are insensitive sayings that we use, even if we've been using them for the last 3 decades. It's something that we should work on because we do not know someone's history of trauma. So here are a handful of things. I imagine these terms will come up in our case discussions as well as the didactics. So you can see on the avoid column, by saying someone suffers from a condition, it's better to say someone lives with or they have. And when talking about a specific health condition, rather than labeling someone as a diabetic or a schizophrenic or a drug user, just saying a person with diabetes, a person with schizophrenia, a person who uses drugs. Talking about things such as blood pressure readings and A1C levels, it's better to not attach a value label saying it's good, bad, or poor. And then it's best to not use the word control. When talking about weight, some of the terms that are not used anymore are obese, morbidly obese, and fat. So it's better to just state the BMI or say body weight. In terms of medication taking, we know that we should avoid the word compliance. One of the newer things is to not use the word adherence. When you're talking about a regimen implies a strict enforcement, and it also implies that someone's following orders. So it's better to say a plan or choices, and that encourages shared decision-making. When talking about things with blood pressure as well as blood glucose levels, rather than saying testing it, it's better to monitor. Again, when we're talking about control for hypertension as well as blood glucose levels, manage is a much better term to use. And then lastly, there are times when we're going to be discussing emotional well-being. If one of the cases goes over suicidal ideation, or if we have to talk about suicide, died by suicide is the preferred terminology over committed suicide. So it is difficult to change our language, especially after we've been using it for so many years, but this is a perfect opportunity for all of us to practice in a safe environment. So I look forward to everyone working on these terms. I myself do it as well. Thank you.
Thank you, Liz. I want to echo, it does take practice. I think I've gotten a lot better myself, but I still don't follow every recommendation. There's just one I would throw in there. I was on the National Academy of Medicine's Obesity Education Committee, and the preferred term rather than losing weight is to achieve and maintain a healthier weight. So make sure you use that terminology, that language, if you can. Of course, nobody's perfect, but we'll try to do the best we can. So we're going to switch to a completely different topic right now. And so this series is entitled Innovations in Diabetes and Cardiovascular Health. And so we touch upon new developments or things that are generally underused. And that's one of the things I'm going to discuss this morning. And it's out of office blood pressure monitoring. And I direct a diagnostic center here at university hospitals that's funded by ARC called the UH Advanced Center. And within that center are 3 demonstration projects, one of which deals with home blood pressure monitoring in adolescents. But what I'm going to discuss is broadly applicable to patients in general. So after this very brief didactic, I hope that people are able to describe the procedure's advantages and disadvantages associated with 24-hour ambulatory blood pressure monitoring, the advantages and disadvantages of home blood pressure monitoring, and where and how patients can obtain home BP monitors. Next slide. So here's a few brief words on 24-hour ABPM. Certainly something that we don't in primary care order very often, and there's some, finite, very, very good reasons for that, which I'll talk about in a moment. So basically, a 24-hour ABPM is a device that's worn on the upper arm, and it measures blood pressure at least every 30 minutes over 20 to 24 hours. It's a minimum of 30 daytime and 7 nighttime measurements. More typically, the frequency is every 20 minutes during the daytime, every 30 minutes at night. The patient can take the device off to shower or periodically just, they have an itch, for example, but they're expected to put it back on. And those minimums are what is the standard for an acceptable 24-hour ABPM. It is the currently accepted gold standard for measurement of blood pressure worldwide. So if you want to know if your patient has hypertension or how bad it is, that's what you want to do. It's much more closely correlated with cardiovascular risk than office blood pressures. And we're all familiar with some of the limitations of office blood pressure. Patient comes in, blood pressure is very high, you check it again in 10 minutes, it comes down or it doesn't come down. And they say, I don't understand, doctor, when I was at Giant Eagle or wherever it happens to be, I had my blood pressure taken, it was just fine. And that's a significant problem. So there are specific indications for ABPM, identifying white coat hypertension, in other words, blood pressure that's high in the office, but normal outside of the office. Masked hypertension, which is kind of the opposite. In other words, it seems to be okay in the office, but it's high in other settings. Nocturnal hypertension and the phenomenon of non-dipping, which is very important. So blood pressure drops at night in patients in whom it does not drop and stays high. They are at extremely high risk of cardiovascular events. And perhaps most importantly, monitoring response to treatment. So many of us have been in the position in primary care, we've started a patient on 1 or 2 agents. We're pretty convinced that they are well engaged in terms of taking their medications. They take their medications regularly. They're sincere about that. They're being filled. They're taking them the right way. And yet the blood pressure is still high. So what do? Do I add another agent? They're really not into that. They don't want to take a 3rd medication just for blood pressure. Or do I make sure that this is a genuine phenomenon where the blood pressure is not well controlled? So that ABPM does provide us some valuable information in that regard. So here's a few more words on it. The thresholds are a little bit different. These are adult thresholds. In children, we use quite a different set of criteria, but we'll talk about these first. So it's an average of at least 130 over 80, which is the blood pressure threshold for office BPs, daytime average of about 135 over 85, and nighttime average of at least 120 over 70. So blood pressure, as I noted, does drop significantly at night. Now, the disadvantages are quite significant. Here's what I have to do in my institution to do a 24-hour ABPM. I have to put it in order into our electronic health record, print it out and give it to the patient. Then the patient has to call a specific number and go to one of 3 different locations here in Northeast Ohio to pick up the 24-hour ABPM machine. One of those locations happens to be the place where I see patients for our Fit or Me program. So it makes it a little bit easier. And the people that work there know that I'm interested in ABPM, so they've set it up. But the other 2 locations are not easily accessible to the patient. So they've got to go there and pick it up. A nurse at those locations will educate the patient, if he or she has time to do so, on how to use the ABPM machine. They pick up the ABPM machine, they hopefully will use it properly, and then they have to return it a few days later to the same location. Then the data is downloaded by one of our cardiologists, And actually, Dr. Neeland is the one who reads a lot of our ABPMs. He's going to be giving us a session later on in this series, and he will send a report, and it's sent into the electronic health record. It's all way, way too much for something that should be very, very simple for us to do. Here's the other big problem with these devices. Well, I don't want to get into the politics of this, but this is a pretty typical price, $2,500 per device for this thing. There are just a few companies that that manufacture these, Welsh Allen, Space Labs, and a couple of other companies as well. The problem is there are validation protocols for 24-hour ABPM and for home blood pressure monitoring, which are very, very expensive to carry out. So there's this international society that validates devices, medical devices. They require a certain minimum number of patients, minimum activity, right? Minimum number of readings, etc. That's very difficult and very expensive. So there's just a handful of companies that have access to these devices. How many of us would feel comfortable issuing a $2,500 device to a patient to take home and to return? It's a big question. Now, adults, it's less of an issue. My colleague Tammy Brady at Johns Hopkins, who also studies pediatric hypertension, bought a whole bunch of these and said the vast majority were damaged or lost. It was a huge expense as well. So this is one of those considerations. And besides, the cost is prohibitive because it limits the availability. Not every primary care office is going to say, for example, let's get a couple of these devices and see what we can do. So there has to be an alternative. I did purchase myself a couple of inexpensive Chinese 24-hour ABPM machines. I tried one out on myself, and it was very loud every time it inflated, but it correlated well to the Welsh Allen device. It was $120 to buy those. So if anyone wants to try them, I've got some in my office as well. So this is my own experience with home blood pressure monitoring. So I've been studying pediatric blood pressure for nearly 20 years. And I mentioned this many times in many different series. I got turned on to this when I was at the University of Pittsburgh, and I was the director of the Pediatric Obesity Center there. And, there was a third-year student who showed up in my office, and I was like, oh, he was looking for a research project. And I said, this is the last thing I need. I've got enough stuff to do. But I told him, why don't you go to the primary care clinic upstairs and do some chart reviews? This was an epic to find out, how many kids have high blood pressure and what's being done about it. And so he went up there, and I think he reviewed about 50 charts, and this was his project. And the most striking thing he found was a child who was a 13-year-old African-American boy, and that's a group that's at high risk of hypertension. He had 3 blood pressure readings that averaged 180 over 100. And there was absolutely nothing in the chart about this. Everything else was beautiful. His immunizations were up to date. His asthma was well managed. Anticipatory guidance about a whole bunch of things, well written in the notes. No nurse, no provider made any note about this sky-high blood pressure. And I thought, hey, we have a problem here, don't we? So that turned me on to the idea that we are not making a good diagnosis. And so in Chicago, we initiated a large study in multiple practices to improve diagnosis of hypertension. And we did. However, when we went back to the providers who participated and asked them, well, how come you didn't even do better than you did? We didn't ask them that way, of course, but, and they said, it's not really us, it's the patients. It is a really big challenge for us to measure blood pressure in the office. You got to wait for 10 minutes till the child is calm, and then they have to come back 2 more times to get additional readings so that they can be averaged and for us to make a diagnosis, and sometimes they don't come back. So this highlighted to me the terrible inconvenience of measuring blood pressure in the office, as well as the inaccuracy. Next slide. So, and the other big problem, children and adults, and Rick, we can try playing this video if you want. Now, this is obviously as a child, and he was the ideal child for measuring blood pressure. I can tell you, for those of us who care for children, he's like 1 out of 100. I know for a fact, this is my colleague Kate's son, and he was 6 years old at the time. He's a practically a teenager now. My own daughter was running around like crazy. You could not measure her blood pressure, but he was the only kid we found that we could do it. He actually liked having blood pressure measured. So that's another problem. How is this relevant? It's also relevant to adults as well. So there is something about the process of measurement that can make patients a little bit nervous and make the results inaccurate. So here is the bottom line that I want you to keep in mind. And we don't have time to go through all the evidence and all the benefits, but here's the sentence to remember. Every patient with hypertension should be measuring blood pressure at home. Why? Well, the reasons are quite numerous. It is better correlated with 24-hour ABPM and cardiovascular morbidity than office blood pressure values. It encourages patient-centered care. We're going to talk about empowerment later on in this series, but there's nothing more empowering when a patient, an 85-year-old patient, comes into me and says, here's my blood pressure values. I wrote them down in this notebook. Can you take a look at these? I don't know why my blood pressure is high. That's a highly engaged patient, and that's something that most of our patients can accomplish. There is unequivocal evidence. HBPM, home blood pressure monitoring, improves patient outcomes, probably through the increased level of engagement and empowerment. The next point, these are not expensive devices. They are inexpensive and widely available. Roughly 2/3 of patients, 60% of patients with hypertension already have a device. And if you ask your patients, do you have a blood pressure device? Many of them will say, yes, they do, but they don't necessarily use it. And if they don't have one, my husband has one, my wife has one, my son has one, my mother has one. It's extremely common. You can get one on Amazon for about $30 or $40. They are very, very easy to use. This is one of the best videos I found. So all you have to do is send that link to your patient's cell phone. 95% of our patients have smartphones, and say, look, okay, I'm going to prescribe an HBPM device. Let's watch this 90-second video while I'm printing out or faxing the prescription for the device. It's that simple. It's consistent with remote care. So during the pandemic, it changed a lot of the ways in which we deliver healthcare. And it was not always in person, but it is nice to see on video someone checking their own blood pressure and then showing you the value on their device at home in a nice, calm environment. And finally, perhaps most importantly and most relevant to this series, it promotes health equity. This is an article from Health Affairs, which is a very influential health policy journal from 2018. And Helen Burston, et cetera, are on. Marshall Chin is at the University of Chicago. These are people that have studied health disparities with respect to cardiovascular risk for many, many years. But these are some of the important considerations here. And I don't want to get into all the details, but it talks about one example of an effort to improve blood pressure control among African-American adults at Morehouse School of Medicine in the Atlanta area. So it's an intervention that consisted of telephonic lifestyle and diet counseling by trained nurses. And of course, we all have those things, and the use of home blood pressure monitoring. Program increased the frequency of self-monitoring of African-Americans and systolic hypertension control by 50%. That's a huge proportion. Without getting into the details, if you look at what specific intervention, if you tease this out, which of the interventions, dietary counseling, telephonic lifestyle counseling, or just giving them the device, which of those was most responsible for improvement in control? It's issuing the home blood pressure monitoring device and teaching patients how to use it. Overwhelmingly the most important thing that we can do. So here are the indications. They're deliberately broad, and I said at the outset, every patient with hypertension should have this. Of course, if you look more specifically, you can identify white coat hypertension, masked hypertension to confirm the diagnosis. Now, we are doing this as an alternative to ABPM. I think the purists will tell you, no, there's no replacement for ABPM, but my goodness, it's difficult to get that 24-hour ambulatory blood pressure monitor. The other thing I have found recently among my older patients is that even if they have the device, I'm not getting the minimal number of readings necessary for a valid 24-hour reading because they find it very disruptive when they're sleeping in particular. It's useful for monitoring and medical decision making. And here's another indication for it. Okay, all of us are going to be discussing patients who have many different challenges in terms of social determinants of health as we go through this series. And one of the challenges is, how do I motivate, how do I empower my patient to take care of themselves so that I can take better care of them as a patient as well? Maybe it's fine to say, look, okay, your blood pressure is not very well controlled. You have obesity, your diabetes is not well controlled. Here's what I'm going to do. I just want you to get this device, measure your blood pressure twice a day for a few days, and let me know what you find. Okay. Now, they may or may not do that, but if they do that, it gives them a sense of control over their own illness that they would not have otherwise. In other words, they're not just receiving new prescriptions for medications. They are not being asked to engage in lifestyle behaviors that perhaps are too difficult for them, but this is relatively straightforward. So there are different protocols for this, but generally speaking, you take 2 values in the morning and 2 in the evening. The minimum is 3 days, according to George Sturgio, but it's preferably 7 days. I haven't seen too many, even the $20 machines, as far as I know, will store the values and average them together. There are slightly different standards for home blood pressure monitoring, daytime ABPM, nighttime ABPM in 24 hours. But these are the values for HBPM. So blood pressure in general is a little bit lower at home, but for the most part, we're using thresholds that are very similar. Next slide. How do you get one? I wish this was even simpler. I'd love to just send a prescription over to CVS or Walgreens, but for our Medicaid patients, there are certified durable medical equipment providers in each region of Ohio. So in my region, which is the Northeast, and this also covers other regions as well, the certified provider is Edge Park. And if you go to the Edge Park website, they have an order form that you fill out, you print out the form and fax it to this number. And they are able to pick it up. I believe the patient can pick it up. I don't know if they will deliver it. They may deliver it. But there are different providers in different parts of the state. For some reason, Columbus has quite a few, these 4 that can help you out. But generally speaking, it's going to be Edge Park in other parts of the state as well. It's important. So I think, thinking about the workflow, from a healthcare delivery standpoint, you've got your patient with hypertension. They may or may not be well controlled, or they may even say something like, I went to the pharmacy or went somewhere else and my blood pressure was normal. Well, here's one thing you can do. You can say, I want you to check your blood pressure twice a day for 3 days, preferably every day. And I'm going to fax this over to you. And then you text them the video link that I showed you. You don't even have to explain it to them. Just text them and say, watch this, see if you can get your blood pressure. Most people are able to do this unless they have some sensory deficits, if they have visual impairment, etc. But even then, they can usually find help that will help them out. Okay, next slide. All right, I'm going to take a few questions before we move on to our sample case this morning, which I'll discuss as well.
I had a question regarding one of the slides. Specifically, I wanted to, at least I'm thinking it had to do with comparison of the home blood pressure home blood pressure cuff monitoring versus the ambulatory 24-hour device. And I don't know if it was basically talking about how they compared, that basically one is a proxy for another, albeit less sensitive. But I just wanted to make sure I understood that correctly.
Okay, so there's a couple of slides, Nathaniel, comparing the two. I think most of it is what blood pressure standard you should use for different ways of measuring blood pressure. So, in the office, 130/80, home blood pressure 130/80, ABPM would be different depending on the daytime, nighttime, or the average. Now, you're getting at a more important question. How does it correlate with ABPM? Home blood pressure values correlate better with ABPM. Remember, that's the gold standard. That's the best. than the office blood pressure values. So if somebody tells you, and they've been checking their home blood pressure regularly over a couple of weeks, and they say, gosh, this is my value, it's more believable, it's more credible than the values that you would get in the office.
Understood.
Okay.
Yeah.
Any additional questions?
Yeah, Goutham, just a couple additional comments as one of the authors of the guideline, the AHA guideline, and the scientific statement from the American Heart Association on blood pressure measurement. A lot of discussion regarding the values for home BP versus ABPM. The one is that certainly both are more predictive of long-term outcomes compared to office readings. And in fact, home BP, if you have a choice, if you're getting different readings from home BP versus office readings, and you know the patient is using a validated instrument and are using proper technique, then you're better off even titrating medications. The recommendation is even you do medication titration using the home BP monitor in preference to the readings that you get in the office. The other is that this slide shows that the threshold for diagnosing hypertension by ABPM is in fact 130/80. And certainly the same for home BP. For titrating medication, and the target or the goal for blood pressure control with the home BP, and for home BP is 130/80. For ABPM, it's 125/75. So that there is that difference. But the key, I think, is that the home BP monitor data are certainly just as or very effective, and both for the management of hypertension. And I certainly agree that every patient with high blood pressure should have and know how to use a validated home BP cuff.
Thank you, Jackson. And thanks for clarifying the titration level for ABPM as well. Much appreciated. I think that, one of the final things to discuss is, why is this not happening as often as it should in primary care? And I think this is really from a primary care provider standpoint is a bit of a knowledge deficit. So exactly what Jackson stated is not familiar with to a lot of primary care physicians. We assume those office values are the ones that we ought to act upon, and we intensify treatment based on that. But as he said and I've said, everyone should have a home BP monitor. And it would be great if we could just issue them from the office and then bill Medicaid, but we're not quite there yet. Okay, I think I need to turn it back to Claire for a moment, and we'll talk about next week.
Sure. So this is just a reminder to everyone that you can go back and view either past echo clinics if you'd like to. They're all on our website, or you can sign on to an account on our website. If you ever miss a week or something like that, you can view the didactic presentation. We do keep the case studies kind of locked, so we do not put those on the website, but you can see the first half of clinic anytime you need to. Next page. And then just a couple of reminders. So each week I send a post-clinic survey. I will send it to you within the next couple minutes. It'll end up in your email. It takes maybe a minute to fill out. It just gives some feedback on today's session. If you have not sent your case studies in, please do that by the end of this week. I'm trying to create a schedule for people to present, and it helps to have as many cases as we can on the schedule. If you want to submit a third case, let us know. We are a little bit short on cases, so just reach out to me if you want to submit another one. If you ever have any questions, please feel free to reach out to us. We're really excited to get this clinic started.
Okay, thank you, everyone. And we will see you all next week. Have a pleasant week ahead. Thank you.